is the heart of ultrasound breast imaging, and understanding the fundamentals of BI-RADS helps one to build your knowledge and approach to assess breast pathologies using ultrasound. So I'm very happy to invite Dr. Liang to put light on this very important topic. And all of you enjoy the next 1 hour of learning the A to Z of breast ultrasound, all you need to know about the lexicon from Dr. Mary Liang. So over to you, Dr. Mary.
Thank you very much, Trishna, for such lovely and kind introduction. Let me just share my screen first. Now I'm going to be taking off my video so that you can have the full screen of my PowerPoint presentation. Today's talk is on BI-RADS Lexicon for ultrasound. Now, just bear in mind that I'll be talking about the ultrasound aspect of the BI-RADS Lexicon today, so we will not be talking so much about the mammography and the MRI. Today's objective is to define the ultrasound terminology of the BI-RADS Lexicon so that the audience can use it in everyday practice. I hope to also clarify the BI-RADS categories for daily clinical use. Just a short history of the BI-RADS Lexicon. It was first published in 1993, with the second edition happening at 1995. With the third edition at 1998, it included the Atlas of the Descriptive Terms. And then in 2003 was when the ultrasound and MRI were included in the lexicon description. And then now we have the latest in 2013, which is the 5th edition, which we'll be talking about today. Now, as we know, BI-RADS has been so successful that if you go into the ACR website, this is the link if you are interested, you can actually go and you'll find that there are BI-RADS. There's also LIANG for the liver lesions, the high-RADS for the head injury, lung-RADS, O-RADS for the ovarian lesions, high-RADS, we all know about that one, prostate, and high-RADS, the thyroid. Now, when the ultrasound BI-RADS lexicon was included in 2003, it abides by the principle that wherever possible and appropriate, the established descriptive terms in the lexicon for mammography were utilized for ultrasound interpretation. This is so that it minimizes confusion and to keep the reporting in consistent manner. For the next remainder of the time, I hope to go through the entire lexicon terminology, mainly looking at the pictures so that we can kind of understand what they mean. So the first out of that is tissue composition. Now, tissue composition used to be referred as a background echo texture, which with the most recent lexicon has been renamed as tissue composition. Tissue composition may be homogeneous. Sorry about that. My Siri is trying to find tissue composition. Okay, tissue composition may be homogeneous background, which may be predominantly fat or fibroglandular. It may also be heterogeneous background. This is an example of a homogeneous background, predominantly fat. This is homogeneous background, predominantly fibroglandular. And heterogeneous may look something like this, where there are multiple areas of increased and decreased echogenicity all intermixed together. This often happens in younger breasts, and their mammogram may look like this. Going on to the description of mass, it can be described in terms of shape, orientation, margin, echotexture, and posterior features. Now, we will go through the shape first. A shape may be oval, like this. It may be elliptical or egg-shaped. Now, you're allowed 2 to 3 gentle undulations. These were previously described as gently lobulated or macrolobulated. They tend to be parallel to the skin. The orientation we will cover in a later part. In terms of the shape, I want to just focus on the shape right now. So this is an oval or elliptical shape. This is a round shape. So the AP diameter is the same as that of width, like a ball. Then you will have the irregular ones, which is not oval, it's not round, then they're irregular. Kind of like the star that my son made for me the other day. A lesion can be described along the orientation. Now, orientation is described relative to the skin. So it may be parallel to the skin, such as this, where you've got the longest axis of the lesion, which runs parallel to the skin. Now, you are allowed a little bit of obliquity, but say if the obliquity runs along closer to the parallel rather than vertical, it will still be considered as a parallel lesion. But let's say you've got an oblique lesion where the long axis points more upwards than it does horizontal. Or if you have a lesion which is almost perpendicular to the skin, then these ones will be classified as non-parallel. This is parallel, this is non-parallel, such as this lesion here, where the longest axis of this lesion is through this way, which is non-parallel to the skin. So the non-parallel orientation may also apply to a round lesion, because remember, the AP diameter and the width is the same. Going on to the margin, margin describes the interface between the breast tissue and the lesion. We're not talking about the shape anymore. It may be circumscribed. I'm using the same image deliberately so that you can see the different terminologies being used. It is circumscribed because it is well defined. You can draw all around it. It has abrupt transition, which means this is tissue, this is lesion. I know exactly where the tissue ends and where the shape begins. This is non-circumscribed, when the margin is indistinct, or angular, or microlobulated, or spiculated. Now, you don't have to just use one. One lesion may have many of these features. Previously described lesion boundary, such as the echogenic rim, has been omitted in the most recent lexicon. This is the update there for you. Moving on to the non-circumscribed margin. This is an example of an indistinct margin, where you can't really figure out where the margin starts between the breast tissue and the lesion. There is no clear demarcation there. This may also include the lesions that have had echogenic rim from the previous lexicon. And you would describe it like this: margin, not circumscribed. And then you would describe what you mean by non-circumscribed further by saying it's indistinct. A non-circumscribed margin may also be angular, where you've got these sharp corners which are coming out of the lesion. Kind of like my star when you look at it, these sharp corners here. They can also be microlobulated. And just notice how it is described. Under margin, non-circumscribed, microlobulated. Microlobulated is different from the gentle undulation in that it has short cycles. Goes in, goes out, goes in, goes out. Then you have the spiculated margins, the non-circumscribed spiculated, where the sharp lines radiate from the mass, almost penetrating into the adjacent breast tissue. That is the margin, circumscribed and non-circumscribed. Now we're going to go into the echo pattern of the lesion. It may be anechoic, which means that the actual lesion itself has no sound transmission, if you like. It looks really black. Or it may be hypoechoic. It may be isoechoic in relation to the breast parenchymal fat. It may be heterogeneous, or it may be complex cystic and solid, which we'll go on to describe a bit later, and hyperechoic. I'll show you examples of all. This is an anechoic lesion. This was a cyst. It looks like a black hole. There is nothing here. No dirty debris, no internal echoes. Hypoechoic also looks dark, but it doesn't look like this. And when you compare it to the adjacent breast parenchyma, it looks darker. Then you have the isoechoic lesions. Now, these can be very tricky to pick up on the ultrasound. And you may need to pull out all the guns that Dr. Trishna had beautifully described in her previous talk last week. You may need to use harmonics. You may have to work on your focal zones, your gains, to be able to really delineate these ones. These are the isoechoic lesions, the ones that are very similar to the echogenicity of the surrounding fan. They may be heterogeneous. Now, this is an added term to the current lexicon. Now, just because a lesion is heterogeneous, it doesn't have prognostic value. It means that just because it is heterogeneous, it doesn't mean it is malignant, nor does it mean it is benign. For example, you can have a benign lesion, such as a hamartoma, which can look very heterogeneous, which the case is this one, where you've got areas of hypoechoic and hyperechoic changes within a lesion, but this almost has that breast and breast kind of appearance, doesn't it? Then you can have the complex cystic and solid lesions. This is a cystic component, and this is a solid component. This was renamed or further described because there was a lot of confusion and a lot of differences in usage with complicated cyst and complex lesion. So now it's been expounded to say complex. Then you have the hyperechoic lesions. Now, this is relative to the fat, and you can see that this area looks a lot more whiter, if you like, than the surrounding breast tissue. Actually, this was an abscess, so on real time, you can see the mobile internal debris. Next to look at is what happens to the sound beam posterior to the lesion. That is called posterior feature. Now, when the echogenicity of the area behind the lesion is same as that of elsewhere, this is described as no posterior features. When the sound beam behind the lesion looks more echogenic compared to the adjacent breast tissue, this is described as enhancement. When the sound beam completely attenuates out, this is described as shadowing. Now, shadowing can happen for a lot of reasons. This is a descriptive term. I just want to remind you, they don't necessarily point completely to a benign lesion. For example, when you've got posterior acoustic enhancement, it doesn't necessarily mean they're all benign. Similarly, just because you have lots of shadowing, it doesn't mean that they are malignant. For example, in this particular case, you've got this echogenic lesion or a focus, which is causing shadowing. This was actually a big popcorn calcification that was seen in the mammogram. Another thing that causes posterior acoustic shadowing may be things like desmoplastic response, fibrosis, such as surgical scar. These can cause shadowing as well. And also bear in mind, if you have a high-grade malignancy, which is growing rapidly, you can also have posterior acoustic enhancement as well. So these are descriptive terms. In terms of the posterior feature, the last one is a combined pattern. Combined pattern is when part of the area causes posterior acoustic shadowing, such as perhaps here, Part of the area causes posterior acoustic enhancement, such as perhaps here. And then in some areas, there is no changes at all. This was actually an IDC. Another time that this might happen might be, for example, fibroadenoma with big chunks of calcification. They can also have a combined pattern as well. It can also be seen in lesions which are evolving, such as post-surgical seroma. This particular example was an IDC. You'll see these pictures probably popping in again and again. So we covered tissue composition. We have covered masses. Now we'll go on to cover a little bit about the calcification. Now the calcification may be outside of a mass. I'm sorry, the images are quite blurred, but essentially what you've got are these tiny little echogenic foci, but there is no discrete mass that is associated with it. Now, bear in mind, when you've got microcalcification that you can see on mammogram, they may not actually cause posterior shadowing. So if you see this, but you don't see any posterior shadowing, please don't let that put you off from evaluating them as calcification. But on the same token, though, just because you have echogenic foci, it doesn't mean that they are all calcifications. Calcification can be also in a mass, such as this. See how this one also doesn't cause any posterior acoustic shadowing. This is in a well-defined oval lesion, and it's got echogenic foci within it. Now, in the most recent lexicon, they don't classify them as micro or macro calcification in the ultrasound. Calcification may also be intraductal. This is an added description. Now, look for echogenic flecks with surrounding tiny dark areas, such as this. That's calcification done. Now we're going to go into the associated features. Some of the categories here have been added. We'll be looking at architectural distortion, duct changes, skin changes, edema, vascularity, and elasticity assessment. The first of them is an architectural distortion. Now, distortion essentially means the same thing as a mammogram, where you've got distortion of the structures nearby. It may be ducts, it may be fibroglandular tissue. You can see in this tall or non-parallel lesion, you get the impression that these lines that are coming in just kind of gets pulled into this lesion. This one kind of was going straight and then it gets pulled into the lesion. This is what an architectural distortion may look like. Another associated feature you should look for is duct changes. This image is actually straight out from the lexicon. I included it because I thought it demonstrates the matter most best. Remember, normal ducts are regular and they become narrower as it goes distally. So with regards to duct changes, things you're looking for is irregular caliber, extension into a abnormal mass, which I'll show you an example of. You might have echogenic debris or solid lesion with internal vascularity. This particular example here, it showed this kind of an echogenic debris sort of thing, which was biopsied, and it showed mucocele-like lesion. But upon excision, it was diagnosed as ductal carcinoma in situ with ADH. Look at this example. We saw this mass before. This one also has an intraductal component, which radiates and extends towards the nipple. This is concerning for nipple involvement. Associated features should also look for skin changes. Now remember, the skin thickening, when it's more than 2 millimeters, it is considered skin thickening. Bear in mind, though, around the periareolar location or in the inframammary fold, they may be thicker. So here you're allowed up to 4 millimeters. When you're describing skin changes, also look for any evidence of skin retraction, such as the case here. When you have skin changes, you may also get edema. Edema is when you get increased echogenicity and reticulation. So see how they've got these angular hypoechoic lines, which are kind of irregularly going in to these other areas of echogenic change. These hypoechoic areas may represent dilated lymphatics or even interstitial fluid. Now, this could be due to a malignant condition, such as an inflammatory breast cancer. But bear in mind, other things can also give this appearance too. Anything that causes edema can. For example, mastitis can, or even systemic causes, such as congestive heart failure, fluid overload. They can cause edema and give this appearance of the breast. Another associated feature that one should describe and look for is vascularity. So look, there is an anechoic lesion with no internal vascularity. When we are talking about vascularity, also bear in mind we are looking at it relative to the normal area. So in itself may not be the diagnostic feature, as in just because you have internal vascularity, it is malignant. No vascularity doesn't mean it is benign. It is a descriptive term. Now, remember though, the Doppler evaluation really depends on the technique as well. For example, if you set the sensitivity setting wrong, it can look non-vascular. If you compress on the breast tissue with your transducer, it can make the vascularity less. So just bear in mind of these technical things as you consider vascularity. This is an example of a florid internal vascularity. Now, remember, abnormal internal vascularity can help you even when there is no mass. This is an example from the BI-RADS Lexicon, where you've got tiny little foci of echogenic changes. There is some altered echogenicity here, but there isn't really a focal mass. Then you put a Doppler on, you see this very florid vascularity. This was actually DCIS. So remember, vascularity can be increased without a mass. You may also have vascularity peripherally, such as the case here. These are actually abscesses, and it had peripheral vascularity. Now, elasticity was very nicely covered by Dr. Trishna last week, and I think we still have talks which will go on to it. So I'm just going to very much touch base with it, okay? Elasticity is an added component in the lexicon, which looks at the stiffness of a mass. You measure this either by strain, where you do manual compression, or shear wave by sending an ultrasonic energy into the mass. As you know, it can downgrade or upgrade a lesion, and it is a very useful associated feature. But I do want to highlight to you that the color coding is not standardized, and I'll show you some of the examples of this. So please check on your images and on your machine what is stiff and what is soft. For example, this is an example of a soft lesion. So in this color coding gradient, blue is soft, red is hard. You have surrounding structures which are blue, as well as the lesion inside here. In comparison, look at this image. Blue is hard, red is soft. And the actual lesion itself is predominantly green, which means it's intermediate. So the first one was a soft lesion. Second one is an intermediate lesion. Then you have this one, which is the same spectrum as the first image, where red is very hard. And this is an example of a hard lesion. So the take-home message from here is that always look at your spectrum to determine what the color codes are. And second take-home point is that elasticity, although very, very useful, should never replace or supersede morphologic analysis. Yes, they can help very much to downgrade or upgrade a lesion, but it can't completely turn over your 2D morphology analysis. Let me give you an example. I thought this was a really good example from the lexicon. This is a hard lesion. Everybody can see that this looks ugly or it looks suspicious, and it is very hard. This is a suspicious lesion. By contrast, if you look at the 2D image of this, it's tall, slightly ill-defined margins, although it can be hard to see on projection. But the elasticity looks like it's very, very soft. So can we call this, okay, on 2D, I would have called this maybe, low index of suspicion, but definitely a BI-RADS category 4. Oh, but look at the elasticity, it's soft, therefore it must be benign. No, these two have been histopathologically proven as IDC. So the take-home message from my elasticity slide is, please do not ignore your 2D image. Elasticity is there as an associated feature, as an adjunct to your evaluation. They're an additional tool. They're not there to replace our other tools. So we went through tissue composition, mass, calcification, associated feature, and now we're left with the special cases. This area has also been expanded to include all of these. Let's go through one by one. Simple cyst. This is a simple cyst. It's a benign finding. There are 4 features. It's circumscribed. It's round or oval. This is an oval lesion. It's anechoic. There is no sound being attenuating here. And it causes posterior acoustic enhancement. This is a classic simple cyst. Then you have the clustered microcysts. Each cyst is small. We're looking at 2 to 3 millimeters in size. There is thin intervening septations. There is no solid components. Although the margins look microlobulated, they don't look like my other microlobulated indistinct sort of margin that we saw before. It is very well defined. There is an abrupt zone of transition. This is a microcyst. You may also get complicated cyst. It has all the features of the anechoic cyst. It's circumscribed, oval, and posterior acoustic enhancement, but inside there are internal echoes. But there is no discrete solid components. This is a complicated cyst. Another special case of mention is mass in or on the skin, such as a sebaceous cyst, neurofibromas, very rarely metastasis. Things to watch out for is looking for a lesion which is very, very superficial. And you may see that this is a skin layer here. And the posterior margin of the skin layer kind of dips to include this lesion along the deep margin, such as here. This kind of echogenic thing sort of dips to include this lesion and then comes out again. These are cutaneous lesions. Foreign body, including implants, is also included in the special cases. These may be breast implants, which may be silicone or free injections, such as this one. Surgical sutures, clips also are included in here as well. Lymph nodes. Now, it's normal to have lymph nodes, the intramammary lymph nodes. Often, they have an oval appearance. You may be lucky to have that classic raniform appearance here. They usually are located in the upper outer quadrant, and they can measure up to 1 centimeter. Axillary lymph nodes, of course, can be a benign finding. They can be a bit bigger, up to 2 centimeters. They may again have this raniform appearance. We're looking for a well-defined cortex, thin, uniform, or it may be like this, where the fatty hilum has now been effaced. It's become a circumscribed hypoechoic lesion. Hila has been compressed or displaced. This is a suspicious finding. This is normal. Vascular abnormality is something that you should describe if you see. For example, this is a florid, avid internal vascularity. This is actually a very rare pseudoaneurysm after ST-guided VAB that I took off from the lexicon. We all have heard of that rare phenomenon of the Mondor disease, where you get thrombophlebitis of the superficial veins in the anterior chest wall and the breast, which may look like this with no internal vascularity because it's a thrombophlebitis. Post-surgical fluid collection is also included in this category. Now remember, they can appear really bizarre. They can look really suspicious. So it's really important to correlate with history. And I'll show you an example of this later, but it may need other imaging as a supplement. For example, a mammogram, like a fat necrosis. Now we come to the first quiz. I hope you guys are still awake. Which of the following statement is false? 1, a lesion may be circumscribed or non-circumscribed. Here, I'm just talking about the descriptive terms, okay? Can you describe them as circumscribed or non-circumscribed? A normal lymph node may be present within the breast. When elastography shows a soft lesion, it is always benign. Or number 4, an anechoic lesion can be cyst or solid. We're going to launch a poll now. So have a think. Maybe give you about 30 seconds to just have a think about it and make your choice. Okay, it looks like the poll result is out. Yeah, you're right. When elastography shows soft lesion, it is always benign. Thank you for listening to my talk. Yeah, absolutely. That is the right answer. So a lesion can be circumscribed. As we talked about, the non-circumscribed is the big section, which looks at the indistinct, the irregular, the spiculated, microlobulated, et cetera, et cetera, et cetera. And just as we talked about, normal lymph nodes, yes, they can be present within the breast, predominantly in the upper outer quadrant. This one, an anechoic lesion can be cyst or solid. I just want to show you an example, actually. Most of the time, they are cyst. But look at this one. It really looks anechoic. It looks circumscribed. It's a gentle undulation, so you can probably describe this still as an oval lesion. But look, when you put the vascular Doppler, you actually can see internal vascularity. So just because something is anechoic, it doesn't mean that they are always cyst. Now, we are about 1/3 of the way, probably closer to the half. So I hope you got a better view than I do. This is actually a cafe very much near Kutepot Hospital where Dr. Trishna and I work. And it has got a beautiful view. And the coffee is very nice too. We hope to have more of this once the COVID is over. I hope everybody is keeping safe. Now I would like to go on to the categories. So we're looking at category 0 to 6. I'm not going to spend equal time for all. It will probably be more along category 3 and a little bit more on the category 4. So we'll just get going, okay? When you have a BI-RADS category 0, it's usually used for screening. This is when a patient or client needs an additional view, or they need prior imaging for comparison, or you're calling them on a technical recall. It's exactly the same as a mammogram. Category 1 is when there is a negative exam, or if the findings are normal. Now, when it is category 1 and is a negative exam, by ECRN 6666, it is important to have some imaging. And in our center, this is what we would do. We would do one image in each quadrant, usually radial on orientation, same distance to the nipple or posterior to the nipple in all quadrants, and one retroareolar region behind the nipple. Although the ECRN 6666 don't include the axilla, it is also useful to include it if you have had it evaluated. So that's category 1. Category 2 is essentially the same as category 1, where the interpreter chooses to describe the benign finding. For example, there are many, numerous one of these. They are all anechoic, nicely circumscribed. These are cysts. These are benign. You don't report them. You don't have to report them. So you can choose either you want to do BI-RADS 2 or 1. Or you have this oval lesion, many of them, and they have been stable for a long time. Like 2-3 years, that's what we're talking about. These are benign findings. Therefore, these are in category 2. Now, category 3 is a bit tricky, and I do want to spend a bit of time on this. This is a category that is probably benign. But this is not the one where you feel like my son, who is going to pop up, where you feel like crying because in the middle of your busy list, you have this lesion. You don't know whether to call it suspicious or not, but you don't really want to biopsy it, and you're not really sure what to do. That is not what BI-RADS 3 are for. BI-RADS 3 is a specific entity where the probability of malignancy is more than 0, but it's 2 or less % likely to be. And these are not the indeterminate ones. These are not the ones that you think needs biopsy. These are not the suspicious lesions. I cannot stress that enough. And there are 6 scenarios where BI-RADS category 3 would be applicable. For example, like this. We looked at this lesion just now in BI-RADS category 2. Imagine this is a solitary lesion. And it's a first ultrasound study. We didn't know this lady before this. It's solid lesion. It's hypoechoic, circumscribed, oval, parallel in orientation. It really looks benign. You can put this in BI-RADS category 3. Say you did a follow-up and you realize if there is more than 20% increase in the diameter, it's not a BI-RADS 3 anymore. It is a BI-RADS category 4, and it needs to be biopsied. Say you followed this up and it becomes smaller or it resolves, then it's a benign finding. That's the first scenario. Well-defined, benign-looking lesion, but we don't have any prior to confirm that this is a stable lesion. Second scenario is when you have a complicated cyst. Now, there's been a lot of research where it shows out of the complicated cyst, when you follow them up, 12% proved itself to be solid. 3% out of that proved to be malignant. That gives you 0.3% likelihood of malignancy. So this puts it firmly on that category of more than 0, but less than 2% likelihood of malignancy. So remember, BI-RADS category 3 so far is a benign-looking lesion with no prior to compare for stability. Complicated cyst. I will talk about this a bit later also. Now, the other 4 scenarios, they are here because we don't have data. Further study is required of at least 500 cases to demonstrate if 2% or less benign range or not. So these kind of are the ones that needs an expert opinion. Perhaps it might require a check on table, radiologist to have a look, correlate with other things, such as a microcyst. We saw this before. Now, I have to let you know, if there are multiple cysts throughout both breasts, and you happen to see this as part of it, you can classify this as benign. But let's say this is the only one. You don't have cysts anywhere else, and it is quite deep in the skin. It's very small, and it's solitary, as I said. Then you can put this in BI-RADS category 3 and follow up. This recently published paper looked at 189 women with 196 lesions of clustered microcyst. And they followed them up for at least 24 months. They even did sampling for 38 of them. And they found that none of them had malignancy. There were also other reports which puts the malignancy rate at 0.5%. That's the reason why the microcysts are in the BI-RADS category 3. But remember, if you have multiple cysts everywhere, and this happens to be one of them, it can be classified as BI-RADS 2. So this one, we just need more data. Then necrosis is another one. They can look really scary with ill-defined margins. Maybe it might be non-parallel. It might have posterior acoustic shadowing. Now, the saving grace for fat necrosis is that if you're in doubt but you suspect it, often the mammogram can help. It may even look like this. This is not actually in the same patient, but I thought it illustrates the matter very well. Also, if you suspect fat necrosis, please correlate with history. History of surgery, such as the case here, or history of trauma. Another in the BI-RADS 3 category, because of the lack of data, is refraction shadowings. This kind of shadowing here. Now, sometimes these can be difficult to know whether they are real or not. And there are things you can do on table, such as turn the probe, angle it, to look for an underlying mass. Sometimes altering the pressure, maybe letting go a little bit or pressing it a little bit harder by moving the tissue around and therefore the ligaments around you can see that these may change. Unfortunately, there is no published data on this. So this, that's the reason why they're in BI-RADS category 3. Now, if you're really unsure and you suspect that there may be a hypoechoic lesion here, and you actually don't think it's a refraction shadow and it's really persistent in whatever maneuvers you do, please don't put it on BI-RADS 3 and follow up. Any doubt, you should put this in BI-RADS category 4 and biopsy. Surgical scar is another one of the category 3. If you think that what the architectural distortion you see is a surgical scar, you have history of it, sometimes you can see it extending to the cutaneous scar, then you may put this in a BI-RADS category 3 and follow up. Of course, you can also correlate with mammography as well. You can scan this on table, which sometimes can be very helpful when you can correlate the cutaneous surgical scar, like that you can see, with this kind of architectural distortion change. And remember, with the surgical scar, in one view, it should look really nice and linear like this. Although in an orthogonal view, it may look quite ugly or suspicious. So when you have a category 3 lesion, first thing to do, and remember, these are the probably benign lesion, the 6 types of scenarios which we've just talked about, you do a follow-up at 6 months. If it's been stable, then you do another follow-up in 6 months. This will bring you to 1 year from the initial evaluation. If it's been stable, then you bring the patient back in 12 months. Now, by this time, it will be 2 years. If it's been stable, then you may downgrade this from a BI-RADS category 3 to BI-RADS category 2. Some centers, they follow these up for 3 years, and in others, 2. And the lexicon is okay with both. BI-RADS category 4 is a suspicious category. This is when you justify a recommendation for biopsy. This is a very big group of 2 to 95% likelihood of malignancy. So in this lexicon, they have expanded it to category 4A for low suspicion, for B, moderate suspicion, for C, high suspicion. Now, it doesn't really elaborate what should be an A, B, or C. What it does say, though, is that it's a kind of an institution based on their experience, which one you kind of put it. But in terms of reporting, you can just say BI-RADS category 4. You don't necessarily have to say for A, B, C on the reports. This is more to convey within the institution what your suspicion for malignancy a particular lesion may be. So that is BI-RADS category 4, suspicious, 3 subtypes. And they have a different likelihood of malignancy, with obviously the 4C being more than 50 to less than 95% likelihood. BI-RADS category 5 is when you are pretty much certain that this is going to be a malignant lesion. So it's more than 95%. This is when an appropriate action should be taken. This is what the prior lexicon had said, an appropriate action should be taken. But this has been revised now to pretty much say biopsy should be performed in the absence of clinical contraindication. These ones really you have to go in and get sample. Remember this lesion, it was proven to be IDC. This just looks suspicious. It's just a horrible looking lesion. It's not a very good official terminology, but it is irregular. It is non-circumscribed. It has stromal distortion. It has heterogeneous echogenicity. It even has ductal extension with suspicious finding of nipple involvement. It has mixed posterior acoustic transmission. This is a suspicious lesion. You're telling them you really need to go and get a sample of this. In the olden days, they used to say appropriate action because they used to justify just getting a surgery. But in this day and age, when core biopsy is so readily available, a biopsy should be performed. Now, this brings us to the second quiz time. I hope the talk has not been too boring. What is an appropriate BI-RADS category 3? Okay, we're talking about category 3. We spent quite a bit of time on this, okay? Multiple cysts in both breasts. Is this a category 3? Solitary, suspicious lesion in a patient with strong family history of breast cancer. Is this category 3, where you don't know, where you think it's going to be benign, less than 2% chance of malignancy? Solitary, probable complicated cyst in the first baseline ultrasound. Is this category 3? Hypoechoic, non-circumscribed, ill-defined angular margins, non-parallel lesion. Is this a category 3 lesion? I open the poll for you now. So, have everybody had think? It's looking good so far. Oh, excellent. Very, very good. Yeah, I completely agree with you. So let's just go through. Multiple cysts in both breasts. That is a BI-RADS 2. You can even put that as BI-RADS 1. But probably a lot of us probably will report it and say it's a benign finding. Solid, suspicious lesion. We're talking about BI-RADS 4. I mean, it could be a BI-RADS 4 lesion. Depends on what it looks like, but that's kind of what I was gunning for. Solitary, possible, complicated cyst in the first baseline ultrasound. Yes, most of you got it right. I'm very proud of you. Hypoechoic, non-circumscribed, I was looking for a BI-RADS 4, but you could have called this a BI-RADS 5, but it really is not a category 3, okay? Just having a little bit of an eye refresher. This is just my glutinous rice ball. It's got sweet potato in it, but I thought it's a nice representation of what benign-looking lesions are if they were in the breast. If it had black sesame seed, it may be looking a lot better as an anechoic cyst, but I didn't have any. So, now that we're equipped with information, we've got the right terminology. We know how to put them into different categories. How do you present this? How do you report it? This is a very short section, so just bear with me. This is what the lexicon says. Look for indication, look for the scope, give us a succinct description, etc., etc., etc. With regards to scope, you should mention whether it's a targeted study, whether it is a whole breast ultrasound, or if it's an automated whole breast. This is referring to ABUS, the 3D volumetric acquisition. And also, it's helpful to know who performed the examination, whether you checked on table yourself as a reporting radiologist or not. Description of important findings. Describe them along the shape, margin, and orientation. Mention the pertinent positives. Don't give them an essay of all the negative finding as well as a positive finding. It crowds the report and makes it difficult for them to figure out what you're trying to say. Be succinct. And if a mass is measured, make sure to have an image with no calipers. This is important because you need the ones with no calipers to assess the margins properly. In terms of location, look at it in the clockwise phase. So whether it's 1 o'clock or 2 o'clock, and what is the distance from the nipple? This was covered very well by Dr. Trishna last week as well, so I'm not going to go on to it too much. If you have a lesion, get a 3 dimension. This particular diagram is from the lexicon itself. And I just want to hone to you, when you measure, you have to get the biggest diameter. That means even if it's not in a complete radial or anti-radial, whatever, you need to tilt your transducer to get the biggest diameter. Kind of like when we measure the kidneys, we're trying to get the longest axis. Then you get the anterior to superior. Then you turn 90 degrees to this to get the width. When it's a cyst, simple and complicated, you don't need to report every single one. If there's been previous biopsy in any of the lesions, it should be noted in the report. This is where our radiologists shine. Any Tom and Dick and Harry can have a look at the images and describe it, but we need to put it together. Always correlate with other modalities. Always refer back to mammogram and MRI if you have it available. Corresponding upper outer quadrant density seen in the mammogram corresponds to 2 o'clock lesion that is seen on the ultrasound, et cetera, et cetera, et cetera. You need to correlate. You also need to compile them together. Give them an assessment, whether you think this is a BI-RADS category 1, 2, 3, 4, et cetera, et cetera, et cetera, and what you should do about it. You know, that's where you want to really fly. This is our Doraemon kite, which really flew. We can let our report take off as well, so that we can succinctly tell our clinician what you think about each lesion, what kind of management, whether follow-up is required or a biopsy. This is an excellent paper, a pictorial review of the changes, which I would encourage any of the interested audience to read. And with that, I leave you with the very last quiz. I hope this is going to be not too hard. So in ultrasound, if there's a palpable non-parallel lesion with architectural distortion, and you put elastography in its heart, what would you do next? Would you say, I'm not sure, I don't know if it's benign malignant, ultrasound in 6 months is suggested? Or would you just write it off and say, it is an incidental finding, no follow-up is required? Or would you say the lesion requires a biopsy? Or the patient needs urgent surgery, no biopsy is required? We'll open the polls. Right, it's looking good. Oh, great. Thank you very much. I feel really like you got the point of my webinar. You're right. The lesion does require a biopsy. It really sounds like I was aiming for a suspicious lesion. So you're right. It is not in the BI-RADS category 3. Even if it was BI-RADS category 3 and you're putting an ultrasound 6 months, this cannot be the reason where you're not sure if it's benign or malignant. Definitely is not an incidental finding. The patient comes with a palpable lump and the patient needs urgent surgery. Well, I think we can slow down a little bit and get a biopsy first. So in summary, BI-RADS Lexicon can be used in everyday practice of breast imaging. The terms should be used accurately and succinctly. And BI-RADS Lexicon can be used to stratify and manage different breast lesions. I thank you for your attention, and I hope we can all fly, take up to the sky. Take care and keep safe, everyone.
Thank you, Dr. Mary, for your precise and in-depth lecture on BI-RADS Lexicon. We have a couple of questions. It was very well received. I'm going to, with the interest of time, I'm going to read out a few of them to you. And it would be nice if you could address the Q&A session. So first question which we have is, do we put down the BI-RADS scoring in our ultrasound report per se if we do not have a mammogram? If we don't have a mammogram done, what would be your BI-RADS assessment just based on ultrasound? Would it any way affect with or without ultrasound? I hope I'm interpreting the question correctly.
Well, that's a good question. Actually, yes, you can. So in very young patients, for one reason or another, they may choose not to have a mammogram. You can put down the BI-RADS as per the ultrasound. That's why the BI-RADS Lexicon was devised for it. But in most patients, they will have a mammogram associated with it, in which case you can report them together, correlating the findings in both the mammogram and the ultrasound, or MRI and other modalities that have been performed on the patient. But that's a very good question.
Yes, I second your point here that BI-RADS assessment categorization is individual based on individual modality given separately by BI-RADS Atlas. So we can confidently give BI-RADS just based on the imaging done. So another question here is, in case of gynecomastia, what would be the BI-RADS category that would you assign?
Sure, that's also, again, a very good question. So if it's a gynecomastia, it's a benign finding. So you would put that as a BI-RADS 2. Unless, of course, in the area of concern, there is an underlying lesion. And if there is an underlying lesion, then you should categorize it according to its evaluation.
Yes, I agree. And what is needed is a clinical follow-up as a part of management. So it's BI-RADS 2 purely. Okay, another question is, if the patient has a breast abscess, and has imaging features suggestive of breast abscess. So the speaker has a question is that if we know that it is a benign lesion. So can we or should we put this as BI-RADS 2 or we should still call it BI-RADS 4? Only on imaging, no intervention done.
Sure, understand. So I hope I understood the question correctly. If there is a lesion, and we have not done a histopathological correlation, and it looks suspicious, then I think you still need to put it as a category 4 and do a biopsy. But you can put it in your report that this may represent an abscess. Having said that, if it is that the patient already had a biopsy and it is confirmed as an abscess, and you're doing a follow-up for it, then you can put this as a BI-RADS 2 because you already know that this is not a malignant lesion. I hope that clarifies the situation.
Yes, Dr. Mary, it does. Because yes, imaging features cannot be completely 100% suggestive if we do not have intervention done and unless and until we don't have a diagnosis. So based on imaging features, we still call that. Okay, another quick question here. Yeah, it's nice to see that there are a lot of people asking a lot of questions. For intraductal lesions that look benign, do we classify them as BI-RADS 3 or BI-RADS 4? What would you say?
Okay, so if they look benign, and it is the first study, so you don't have prior to compare with to see that if that's been there for a long time, you can still put it as a BI-RADS 2, a BI-RADS 3, I beg your pardon, and you can follow it up. Often these patients, however, may have symptoms, especially if it is an intraductal lesion such as papilloma, is what we're getting at. They might have nipple discharge, for example, in which case the clinical evaluation needs to be done and a patient needs to be clinically managed. For example, if they've done cytology of the nipple discharge and it came back as possible malignancy, then it is well within the surgeon's rights to ask for a biopsy of this. Also, of the note, say if a lesion was found and we put them in BI-RADS category 3 because we thought it was less than 2% likelihood of malignancy, but more than 0%, the patient may opt for a biopsy. But just because a patient asked for it and we did it, it doesn't change our BI-RADS category 3 into a 4. So it's a similar thing to the introductory. That is my interpretation. What do you think, Dr. Trishna?
Yes, I agree with you. We have to correlate the BI-RADS imaging assessment with the clinical presentation. And in collaboration with that, decide what is the management. So BI-RADS can be based on management point of view, or BI-RADS can be imaging point of view. So when it is still, it is a management point of view, we put down in the report that this is BI-RADS 3, but in view of no prior or patient's interest or anything, the biopsy can be performed or as felt clinically appropriate, but that doesn't change the BI-RADS. So you're right in saying that, and I agree. Intraductal lesion that looks benign, if there is no clinical symptom associated and it is precisely benign, then we still can call it BI-RADS 3. But you have to take into account the clinical picture. Okay, so one more question. Good morning, I'm Susan from Indonesia. How we describe BI-RADS for enlargement of breast in male adolescent? Thank you. So I'm assuming the question is targeting on, again, clinical presentation of breast enlargement in male adolescent. So how would you, what would be the imaging? And based on the imaging, what would be the BI-RADS?
Okay. So, yeah, so if you've got breast enlargement in a male patient, I suppose the very first thing that we think about is this gynecomastia? So historically, they used to get a mammogram to see if it has that classic sort of flame-shaped appearance in the mammogram. But in a young adolescent, I think it is also not a bad idea to do an ultrasound because it may be reduced radiation. Historically, we used to not do them because, ultrasound imaging of gynecomastia can look really strange. But I suppose what you're looking for in an ultrasound in a case like this is any discrete masses, because those are the ones you really don't want to miss. And as we know, gynecomastia tends to be bilateral, so you could compare with the other side as well. If in doubt, though, you can always perform a mammogram to confirm. And you can also do, and also, of course, the clinical management is very, very important. So any palpable, discrete lump, those also needs to be managed appropriately.
Yeah. So coming to the last two questions, both of them are falling in the same category, so I would try to put them together. So if you have hypoechoic lesions which correspond to oil cyst on mammogram, would you put them as BI-RADS 3 or BI-RADS 2? And what is the BI-RADS for normal axillary appearing lymph node, but no finding in the breast?
Sure. So those are really excellent questions. These are benign findings. So remember, BI-RADS category 2 findings are what you choose to report. So referring to the oil cysts, if they look like oil cysts on mammogram and they correspond beautifully with the ultrasound, you can either choose to even put them in category 1 because it's a negative finding. Same with the axillary lymph node. So if you can see in the mammogram some lymph nodes, but they're not dense, they have a reniform appearance, they don't look thickened, and you look at the ultrasound of the axilla and there is no lymphadenopathy there, you can choose to put it as BI-RADS 1, actually. You don't necessarily have to report it, include it in your report and call it a BI-RADS 2. If you choose to do so, like say I had a patient the other day that had multiple oil cysts everywhere, then you can always include them in the report and say there are multiple cutaneous lesions in keeping with, or, superficial lesions. They have the classic appearance of mammographic appearance of oil cyst. Finish, BI-RADS category 2.
Agree. Can't agree more. Then we have a couple of questions. Are you happy to answer them now, Dr. Mary, or would you want to take them offline?
What do you think? I'm happy to do either, but I am aware of the time.
Yes, even me, but I think the listeners would be interested to know that answers right away. And in the best interest of time, I'm just choosing few of them now again. Can you have a combination of BI-RADS reporting, like BI-RADS 4 in one breast and BI-RADS 3 in opposite breast? Yes.
Yes, but usually the indeterminate finding will supersede everything. For example, if you have a suspicious lesion in the right breast, the left breast is unremarkable. Your report, you're not going to separate it into right breast report, left breast report, correct? Therefore, the most suspicious finding basically rules the BI-RADS category. So you would report, the report may go something like this. In the right breast, 6 o'clock, 2 centimeters from the nipple, there is a suspicious lesion measuring, et cetera, et cetera, et cetera. Histopathological correlation with core biopsy is suggested. then you'll put BI-RADS 4 or 5 as you see appropriate.
Okay. Yes, the last question, BI-RADS, about BI-RADS 3 versus 4A. Would you give BI-RADS 3 or 4A for a circumscribed oval hypoechoic mass without internal vascularity that is palpable? So basically a palpable finding, which is benign looking oval hypoechoic. Would you call it BI-RADS 3 versus 4A? So I guess we don't have the entire imaging spectrum available in here. We cannot talk about the BI-RADS categorization just based on whether it's palpable or not. What do you say?
This is a very difficult thing, but I think as radiologists, we should probably stick to the imaging appearance because you can have benign lesions that are palpable. But it also means, some palpable lesions are very mobile. They feel smooth, but other palpable lesions may feel really, really hard. And that's where the clinical correlation becomes a really key thing. So if you have a lesion and you feel in your appearance that it is a very benign finding, but it is solitary and you want to put it into BI-RADS category 3, then I think you're well within your rights to put BI-RADS category 3. But you can put a caveat saying that this corresponds to a palpable lump and that the clinical management of the palpable lump is suggested. In these events, the surgeon may decide to biopsy them. And if they biopsy it, it doesn't change your BI-RADS category. It still remains as 3. It just means that clinically, they felt that it needs to be biopsied. I hope that clarifies the question.
Yes. It does. And we have a lot of questions, and I'm just writing back to all of them that we will answer them all individually. And that would be the best thing to do in the interest of time. But thank you so much, Dr. Mary. We are very happy to have a lecture given by you in depth, in so much in details, and it really made it simple to understand a complex topic like a BI-RADS lexicon and how do you apply it in your daily practice. Thank you very much. Anything
Thank you very much for
having
me, and you're a wonderful MC.
Thank you. So yes, we look forward to the next lecture next Saturday. So stay tuned for the upcoming lecture, which is on sonographic features of benign and malignant breast lesions, which may be deceptive. So it's a very interesting topic, and it is covered by a senior consultant radiologist, Dr. Vish Reynolds, and she's going to show you more of case-based and less of theory, but more of case-based, an example of amazing collection she has about how imaging features can be varying in benign, and you should not get carried away with just the imaging features. It can deceive you. So it is a very interesting topic, and I welcome you all to join again next week, Saturday, same time. Signing out for now. Thank you everyone for giving your time on a Saturday morning and listening to a lecture on breast imaging webinar series by GE. Thanks once again.